Hello, everyone. I don't know if I have to say good morning or good afternoon or good evening because I know that you are coming from 21 different countries around the world to listen to our lecture today. So it's a great pleasure and honor to have Professor Manu Shankar-Hari from the University of Edinburgh gave the talk today. So, as many of you know, Manu has a long track of research in the field of sepsis and ARDS, and he is in a very particular situation, having been trained both in epidemiology and basic science with a PhD in immunology allowed him to have a very original approach to sepsis and ARDS by doing translational research. And I know that part of his immunology research is inspired by Genoway's work, which was a pioneer in the field of immunology. So it's very I'm very happy to welcome Manu Shankar-Hari for this today lecture. He will be talking about the importance, potential importance of vaccination for improving patients' outcomes after sepsis episodes. We know all how huge is the burden of sepsis, not only on the healthcare system worldwide, but also on the society more globally, on socioeconomic aspects, and not only because of unacceptable high rate of mortality, but also because too many of survivors are left with sequels and loss of autonomy. So the work done by Manu and by others are very important, not only for researchers and clinicians, but for the society as a whole, because of that major burden that sepsis places on our societies around the world. So without any other words, I will pass the microphone to Manu Shankar-Hari for his lecture. Thank you, Manu.
Djillali, thank you so much for a very kind invitation and introduction. It's really appreciated. You are a pioneer in the field, so very, very grateful for the opportunity to talk about this topic and to colleagues around the world. And thanks again, Djillali. So I've been given the title Vaccinating for Better Outcomes and in Sepsis and Sepsis Survivorship. So just a brief acknowledgement to my funders. I'm largely funded through UK-based research funding programs like the NIHR MRC EME program, Wellcome Trust, the UKRI, and I also held a NIHR Clinician Scientist Award up until 2023. So these are my views, not necessarily of the Department of Health and Social Care's views. I do have intellectual conflicts to declare. As Djillali highlighted, I run a precision medicine program called TRAITS, and I'm also investigating Garches trial, which is a steroid trial in ARDS, and I just finished the first vaccine trial in sepsis survivors called as Garches, and I'm going to briefly highlight that towards the end of my talk. And I'm also chair of the Lancet Commission on sepsis, but those are my intellectual conflicts. I don't have any financial conflicts to declare for the purposes of this talk. I do advisory board activities, but they are managed as unrestricted research funds by the institution. So Djillali highlighted this point about why are we talking about this, and I just want to kind of dwell for a minute or so on this specific topic. When you think about sepsis, we often forget that there is a step before that, which is the infections. And infections can be asymptomatic infections, and you recover. You don't think much about it. We all had that during COVID, where we had pre-hospital mild COVID infections. A lot of people got better. Then you got these symptomatic infections, and sometimes some of these early infections become more symptomatic later. Classic example is community-acquired pneumonia in a patient where you have minimal pauci-symptomatic cap to more severe symptomatic cap. And I think there comes some point in this process where an infection becomes sepsis. And I think that's a very arbitrary kind of categorization. It is absolutely a continuum from asymptomatic or pauci-symptomatic infection to symptomatic infections through to sepsis. And I think with sepsis, we have two words that often kind of are added, the dysregulated immune response and organ dysfunction. I'll pick on those words in the next few slides. Let's carry on with this line of thinking. As Djillali highlighted, there are roughly 50 million cases a year based on the last Global Burden of Diseases report, and the new Global Burden of Diseases preprint on the Lancet preprint server looks like they have estimated a caseload of roughly 160 million cases. So very big numbers in terms of the global health issue. And if you take what happens to patients who have sepsis, you have broadly two outcomes. Either some of them progress on to die, sadly, and some of them progress to recover. And again, the previous global burden of diseases say that there are roughly 12 million deaths a year, and the newer global burden of diseases report saying there are roughly around 30 odd million deaths a year because there are a larger number of cases in their caseload. And then if we focus on the remainder of the patients who recover, sepsis survivorship, for critical care doctors like me, we think that we made a difference because we've made patients better and they get out of intensive care unit. And that is roughly 38 million a year. And if you look at the sepsis survivors in particular, they've got tremendous post-acute sequelae. And it is not just for bacterial sepsis. You've heard a lot about viral sepsis and the consequences of that. And there is also protozoal infections like malaria and other things that cause the same issue. Things like dengue, they all have sequelae, and the sequelae differ. And I think the fundamental issue here in the last point about post-sepsis sequelae is that these patients have healthcare needs, but no healthcare system in the world can say that they follow up these patients consistently and do the right thing. Often when sepsis patients get discharged from the hospital, they don't even have a labeled sepsis. They go back to their primary medical team and then get followed up based on their primary medical condition that they came in with. For example, they may have come in with an acute medicine, cardiac failure. They just followed up from the cardiology point of view. They don't get followed up from a sepsis point of view. So there is a huge problem in terms of both healthcare issues as well as healthcare provision in these patients. And that creates the societal burden that Professor Annane highlighted at the introduction. So if we take this structure, I wanted to ask the question and discuss with you, what are the opportunities to modify this burden when we use a vaccine? I'm not particularly interested in particular type of vaccine. I'm just asking the broad question. If we were to use a vaccine, what are the pinch points where we can actually do something in this scenario? So I found 4 different pinch points where one, you could think about a vaccine that prevents infection. That's your primary prevention. You could also think about the vaccine that prevents the symptomatic infection progressing to sepsis. I think that's an important point that we don't actually think about often. It's a lack of counterfactual, because if you think about a vaccine like pneumococcal vaccine, it prevents pneumococcal pneumonia, and quite a lot of these patients would have progressed to sepsis had these patients not got that vaccine. And then even within sepsis patients who get a vaccine, like for example, sepsis patients often have an endotoxin load. And we often don't think about tackling the endotoxin load with the vaccine that not only tackles the endotoxin, but also the corresponding host response to the endotoxin. Often we tackle just the endotoxin, and that has never led to improved outcome before. Why would a vaccine do that? But if we had a slightly different idea of targeting both the endotoxin plus the host response that goes with it, we may have a different outcome. Now that's number 3. And then the final point is secondary and tertiary prevention in those who recover from sepsis. And I'll kind of dwell on all of these topics by mapping it onto sepsis biology, because that's where I think I bring a slightly different view to the general kind of discussions that often happen. And to kind of get to that point, I want us to just take a couple of minutes just to think about what is an immune response to vaccine look like and what do we need. So this is a review that was led by Andrew Pollard and Elsa Baker, and they kind of make a very beautiful review in Nature Reviews in Immunology. But I just want to pick up on the basic concept of vaccine. If you think about vaccines, you have broadly 2 different things in a vaccine. You have the vaccine antigen. For example, let's keep with the pneumococcal theme. You've got a pneumococcal antigen. And then you've got an adjuvant, which is usually a non-protein adjuvant like an alum. And those 2 combined together generate the vaccine response. And here, if you think about the vaccine response, what you need is an antigen-presenting cell first to take up the vaccine antigen in the adjuvant. And that antigen-presenting cell is a dendritic cell. And the dendritic cell then goes away from the lymph node that drains the vaccine. So if you, for example, if you got a vaccine in your upper arm, the draining lymph node is the axillary lymph node. And then it takes that draining lymph node to essentially show the vaccine antigen to a helper T cell. And the helper T cell does 2 things. It kind of generates a T cell dependent response to the B cells and a T cell independent response that doesn't need a dendritic cell. And then there is also a cytotoxic T cell response. And these combined vaccine responses eventually lead on to an IgG or an antibody response and a long-lived plasma cell response in the bone marrow. And when you get a secondary infection, those then kind of enable you to respond better or prevent that infection from becoming sepsis. And I think this is important to remember, that you need an antigen-presenting cell that is functioning. And often in sepsis, the dendritic cell function is impaired. T cell function is impaired because T cells are terminally exhausted. And the B cell receptor proliferation is impaired because T cell dependent B cell activation doesn't happen. So a number of mechanisms in this simple figure, you can immediately see how one could use sepsis biology to actually say, do we really know whether vaccines would work in a sepsis patient or a sepsis survivor? I'll leave that question for you to think about. I'll come back to it later in the talk. Let's kind of develop this idea of pathobiology of sepsis. And I think I want to kind of go back to fundamental kind of simple immunological principles, because I think that's what will get us understanding better. So broadly, you and me as a human host, we have 3 mechanisms. One is avoiding the pathogen. When we had the pandemic, we all wore masks. When we touch a contaminated surface, we wash our hands. And I think that's the avoidance mechanism. If the food is spoiled, we don't eat it, because that's an avoidance mechanism, that we smell the food and think, this is not right, we don't eat it. That's avoidance mechanisms. That's evolutionary conserved mechanisms, and some we learned behavior. Then there are 2 different things that we seldom talk about in the context of sepsis. One is a resistance mechanisms, and other is a disease tolerance mechanisms. Resistance is often what we kind of loosely call as immune response. And the disease tolerance is a mechanism that prevents you from being killed because of your own response to kill the bug. And that essentially is a host protective mechanism. And I'll come back to this in the next slide. So when you kind of think about now, what do we mean by the dysregulated immune response to infection that we talk about in the sepsis 3 definition and other definition that Djillali has been part of as well. We often have this idea that there is a microbial threat, there is a sepsis state, which is the dysregulated state, and then there is inflammatory signals in blood, and there is organ dysfunction and organ crosstalk at the organ level. And I think I want to kind of take this basic idea and then say, what do we mean by the dysregulated immune response? And I think we published this about a year ago now, where we had not only critical care and sepsis experts, we had infectious diseases experts, experts with cancer like Christophe Letanou from France. We had people who were experts in asthma like Anke van der Zee from Amsterdam, and Ian McInnes, who is a rheumatology expert. So we went kind of broader to ask the question, if we know what do we mean by dysregulated immune response, could we manage this better? And I think we ended up with this definition where we said that the dysregulated immune response is a change in homeostasis on the resistance, disease tolerance, and resolution mechanisms occurring concurrently. And I want us to just talk a bit about these three things in our minds when we think about how do we manage the immune response in a patient with sepsis. Resistance mechanisms are needed. They kill the bug. They reduce the pathogen and kill the pathogen. But when you have these resistance mechanisms like the complement mechanisms and the cytokine response, we also have a cost that the host has to bear, and that is your organ dysfunction. The disease tolerance is a mechanism that essentially reduces the severity of infectious diseases. So you could think about a vaccine that will essentially enhance your disease tolerance mechanisms without affecting the pathogens at all. And I think the way we think about it currently perhaps ignores those principles. And I want to just use one sentence to finish off this part of the talk, which is resolution is different from anti-inflammatory mechanisms. Resolution is a regulated process that requires drugs or appropriate tissue homeostasis for it to function. It is not anti-inflammation. So even though from an English language point of view, resolution could be anti-inflammatory, from a biological point of view, it is not. So that is what we mean by the dysregulated immune response in sepsis. And I think if you frame it this way, you can start to see where there are opportunities. And you will all be thinking, well, this is all very good. Do you have any proof to say that any of this is valid in the context of sepsis? So I want to just bring in one example. This is a paper published in Cell Systems. What the authors have done is to take influenza virus infection, and they identified patients based on their gene expression profile, transcriptome, into groups that have got a resistant state and a disease tolerant state. And they asked the question, does the baseline resistance and disease tolerance state affect outcome? And I go on to show that it's a modifiable program of disease tolerance, and they highlight a gene program called as Aradia program, which essentially highlights that if you have a high disease tolerance program active, your infection severity with flu is lesser. And they validate this principle in an animal model of peritonitis. So these things exist and there is evidence for it. It is just that critical care and sepsis literature haven't really managed to think along these lines to incorporate these principles. And I think once we start to incorporate some of these principles, our understanding of biology will be different. And we have a manuscript that's under peer review highlighting something very similar in critically ill patients with sepsis. And the next question often that when we think about vaccines and infectious threat is immune resilience. And I think this is a lovely cohort work using multiple cohort studies of nearly 50,000 individuals. And the authors go on to identify and tell us what do we mean by immune resilience, where the ability of a dysregulated response to suddenly revert back to normal, that is more or less the resilience from a physiology point of view. And they highlight this using two broad things, the CD8, CD4 profile, and then the survival associated signature 1 and mortality associated signature 1. These are transcriptomics profile using peripheral blood transcriptome. And they kind of highlight an immune resilient state that goes from an optimal state to a non-optimal state. And like most things in life, females have more chance of being in an optimal state than males. And then the immune competence based on the CD8 and CD4 profile and the immune health grades, high is an optimal state, and if the immune health grade is low, which is a suboptimal state. And that is classic sepsis. You got low CD4 and CD8 counts. In terms of the transcriptomic profile, early on in sepsis, we have shown that the mortality-associated signature is very high and the survival-associated signature is very low. In other words, early on in sepsis, your susceptibility to mortality is high, your immune resilience is low. So there are fundamental immunological principles that actually improve our understanding of sepsis as a disease. And it's not complex, but it is important to read about it, because then the way we think about the condition will be different, and therefore we can actually move the field forward gradually. So let me therefore put it all together into an updated immunobiology. The figure on the left is what I told you earlier, which is microbial threat, pattern recognition receptor, effector cells, which are leukocytes, sepsis state, which is the dysregulated immune and non-immune mechanisms, and then we have the altered tissue homeostasis. But actually, one of the other principles that we don't talk about is the scale of microbial threat. As an example, a Staphylococcus epidermidis infection is different from a Staphylococcus aureus infection. And a simple Staphylococcus aureus infection is different from a Staphylococcus aureus with a toxin that is attached to it, like a PVL toxin. Clostridium difficile with a toxin is different from a non-toxin diarrhea. So there is a scaling of microbial threat within the microbial threat idea of sepsis. Then I talked to you about the resistance, resilience, and disease tolerance and resolution mechanisms. And then you must have heard the last lecture by the previous speaker about compartmentalization of immune responses, because the previous speaker, I understand, is an expert in that space. So, you can now see why I spent around 10 minutes explaining that there is a different way to think about sepsis immunology, and that might help us actually at least structure our interventions differently. So now let's come back to the real question that I was asked to talk about, which is sepsis patients have immune consequences that makes them at an increased risk of secondary infections. And I want to kind of take you back to this review that we wrote with Tom Vanderpoel and Joost Wirsinger in Immunity, where we say, look, I think there is a host and a pathogen interaction that constitutes all of these pro and anti-inflammatory responses that you see. There are pathogen factors and host factors that we need to think about. And then within the pro-inflammatory mechanisms, it's not just the leukocytes. There is complement, there is coagulation, and also the necrotic cell death versus apoptotic cell death. A necrotic cell death is often pro-inflammatory, whereas an apoptotic cell death is more anti-inflammatory mechanism. And that the reason being that necrotic cell death often releases DNA, which is a DAMP or a damage-associated molecular pattern, causing more collateral damage. And remember, in sepsis, at solid organ level, Richard Hotchkiss and colleagues have shown that you don't have cellular death in the kidneys, in the heart. What you have is focal necrosis at best. But most of the cell death happens at the immune cells, because the immune cell turnover is increased during sepsis. And there are lots of anti-inflammatory mechanisms, and the potential therapeutics are listed in green in both these scenarios. So, for example, an impaired immune cell you can treat with checkpoint molecules and IL-7, an interferon gamma, GM-CSF, etc. And a pro-inflammatory cell you can treat with anti-C5a, which the colleagues in France did during COVID. There is also soluble thrombomodulin, anti-TLR4, anti-TNF, and anti-IL-1RA. Again, during COVID, we've all tested these interventions. And that kind of framing of the problem that we are trying to tackle takes me to the sepsis survivorship as well. every sepsis patient, because of their early immune effects during the course of an acute illness like sepsis, will have longer term consequences. And I'm showing you a graph that we used using the ICNA case mix program data based in the UK. Over a period of 365 days, 1 in 2 patients have at least one all-cause rehospitalization event following a sepsis survivorship. And about half of those events are infections. And I think the figure on the right, most of the deaths happen following hospitalization. Very few deaths happen without hospitalization. And it gets me to think about 2 different things. One is, part of this is preventable. If we can prevent rehospitalization by treating the infection risk better. Second is, what are the mechanisms that we could target in this particular population? So let me kind of take the immunology to sepsis survivorship. If you take the sepsis survivorship, you have impaired leukocyte function. In other words, if you follow a patient with sepsis and take their peripheral blood and look at HLA-DR expression, their monocytes have got impaired HLA-DR expression and impaired function to antigen challenge. Their leukocytes, particularly neutrophils and lymphocytes, are impaired in terms of their function. They've got low levels of raised CRP. In other words, there is unresolved chronic inflammation in patients who recover from sepsis. The apoptotic cells, we and others have shown that the lymphocyte apoptosis is so profound during acute illness that you often lose memory B and memory T cells. And memory B and memory T cells, I started by the talk by highlighting how important they are because vaccines generate them. And your mild infections generate them. And when we lose those, they don't get automatically replaced. So you can think about sepsis survivors have got an empty memory subset in their lymphocyte repertoire of antigens that they have exposed to. There is also an increase in inhibitory immune subsets, important given the recent Nobel Prize about the regulatory T cells. In sepsis patients, you get an increase in proportion of these subsets anyway in circulating blood and in secondary tissues like lungs. So, therefore, even in a sepsis survivorship scenario, vaccine could be an important intervention to think about. In addition to all of the anti-inflammatory and the immunostimulants you could use. But there are certain areas of uncertainty, and that's important to acknowledge. First is, if we know that an antigen-presenting cell like a monocyte is impaired, will it affect vaccine responses? In other words, does the vaccine that we give will have the same protective effect that you would see in a non-sepsis survivor? Perhaps not, but we don't know. That's an uncertainty. If you got impaired immune system, does that preclude us from using live attenuated vaccine, like a BCG vaccine, which has got some additional effects rather than just protection against TB? So does that mean that we shouldn't give these vaccines? We don't know. Should we or should we not? And when do we give these vaccinations to sepsis survivors? We don't ever think about, well, we have a 66-year-old gentleman who got out of the hospital following abdominal sepsis. And he's going to get the same vaccine schedule as a young pregnant patient who got puerperal sepsis in the community. In fact, the young lady wouldn't even get a vaccine for sepsis after surviving sepsis because they've survived and they're young. They don't need anything more is what we think, but they have residual morbidity. Then the related question is, okay, if we think vaccines is a good idea, what are we trying to tackle here? Are we going for the pathogen-specific effects? There is a problem because we don't know what the pathogen is that is going to cause the next sepsis. Or are we going for more broad effects, like the heterologous effects of vaccine, which I have got a slide coming up. But if we are going for the more broad effects, it is often best seen with a live attenuated vaccine. I told you 2 minutes ago, perhaps that's not a good idea because immune system is impaired. So what do we use? We don't know. And I think this leads to kind of quite a number of challenges that we have in this field of what do we do to a sepsis survivor and how do we vaccinate them the best way we can. And to do that, we need to understand clearly what is the right timing, what is the right vaccine, and what is the vaccine scheduling that we need to do for these patients. And at the moment, we don't know anything. We actually ignore the problem because we don't have a real scheduling issue for sepsis survivors. So let's now map everything together in the last few minutes so that you can see why I kind of was so forceful at the start of the lecture. And I said heterologous vaccine effects. I'm just going to use one paper. This is from Mihai Netia's group based in Netherlands. And they kind of highlight an important point in the vaccine response called as a trained response. So innate immune system is often not thought of as having memory, but they do. And I think Mihai's group have shown that in multiple different manuscripts, both in animal work as well as in human work. And what this innate immune memory does is it trains your innate immune system, particularly the monocyte macrophage system, and they then have protective antimicrobial effects to secondary infections. And I think this is a kind of simple but valid example is in countries where we give BCG vaccination, they have a different response to a new antigen challenge, and there is a lot of literature in that space. When you give a vaccine, you also get this adaptive immune memory that is the more protective effects against the vaccine. If you give a pneumococcal vaccine, you protect against pneumococcus. But the adjuvant in the pneumococcus could do other things. So the three vaccines they talk about in that paper are BCG, MMR, flu, and there is also a zoster vaccine that kind of does have some of these trained immunity mechanisms. So it protects against the target pathogen by generating memory B cells, memory T cells, and antibodies and plasma cells. They also protect against non-specific bugs that are not the primary infection that the vaccine is targeting through either a trained immunity response or a cross-reactive adaptive immune response to either the pathogen or the antigen. And I think given how safe some of these vaccines are, it is worthwhile us thinking about it. So let's kind of come back to where I started the talk. Okay, what are the opportunities to modify sepsis using vaccines? And I think all four of these are tackleable and addressable if we were to ask this question in a much more streamlined and consistent way. Let me give you one example of what we tried to do. So this is the trial that is currently under peer review. This trial used pneumococcal vaccine. I'll explain in the next few slides. And this was funded by the National Institute of Health Research UK. We started in 2017. There was a small problem in between the pandemic, so we are delayed, but we are in the process of hopefully getting the manuscript out into public domain soon. So this was a 13-center study. We had an internal pilot phase of 54 participants, and then we had a full trial involving 214 participants. We did quadruple blinding because this was the first vaccine trial. We wanted to make sure that there is no source of bias or limit the source of bias as much as we can. So neither the participants nor the site research staff nor those administering the treatment, nor the statisticians, nor those who followed up knew what was the intervention. And this was important. And although today we think data-enabled trial is the basic trial that one should do, in 2016 and 2015, that is not the norm, and we felt that was probably where the field should go to, and that's why we did it. We also did embedded biological sampling, and I'm going to show you some examples. So we included patients who are older than 18, admitted to ICU or HDU with sepsis, and they're ready for step down. So this was an in-hospital treatment of these patients. And we excluded anybody where pneumococcal vaccine was indicated, for example, splenectomy, or you had a diagnosis of pneumococcal sepsis, or you had a comorbidity that had immunosuppression, and any other vaccine intervention. So we administered the vaccine when they are clinically better and getting out to the critical care unit. The treatment was PCV13, or the pneumococcal vaccine 13 valent, with a conjugate vaccine. The comparator was placebo, and each trial had a blinded and an unblinded team to allocate this treatment. For those who don't know PCV13 biology or the basic structure of PCV13, this is a conjugate capsular polysaccharide. The aluminum phosphate is the adjuvant, and it's got an immunogenic protein carrier, which is a diphtheria toxin. And PCV13 generates T-cell dependent immune responses. And I think this was important because what we now have is some of the uncertainties that I highlighted before, which is if we vaccinate a sepsis survivor just as they leave critical care unit, will they develop vaccine-specific immune response? If you have a vaccine with an adjuvant, will they get some non-specific effect of leukocyte activation? In the interest of time, I won't go through all of this, but I'll just kind of say that those were our primary outcome, was a clinical primary outcome, and there were several secondary outcomes. But I want to just show you one example of immunobiology that we did so that you can understand why this trial will be important to the field. And the sample size were informed by systematic reviews, and we did 214 patients. So, as I said, we opened in 2018. The internal pilot phase was completed in 2019, and the DSMB said continue without any modification. We paused for COVID between 20th of March and February 2021, and the last patient was randomized on April 2nd, 2022, and the final follow-up visit was 2023. Data enabling and the data linkage took a lot of time because of the various new regulatory changes after COVID. So finally the manuscript is under peer review. And I want to show you something. This is at baseline. PCV13 has got 18 serotypes, and those 18 serotypes are shown here. And at baseline, they were not different between the PCV13 group and placebo group. And at 1 month, which is the standard way to assess, you see here that those who got vaccine, about 6 of these 13 serotypes were higher than the placebo, but there were some serotypes that still were not significantly different to the placebo. In other words, sepsis survivors do mount an antibody response, but their antibody response is not like what you see in a patient without any of the sepsis survivorship problems of immunology that I highlighted. And I've kind of highlighted the individual profiles. In pink is the vaccinated group, and in blue is the placebo group. You can see every single IgG serotype goes up, but the statistical significance when you come to multiple comparisons, only 7 out of the 13 are truly significantly higher. But we do see a vaccine response, and the vaccine response is very variable. So, to summarize the talk, I think Djillali wanted me to talk about sepsis as a global health problem. I hope I've convinced you that it is still a problem. I kind of gave you a different perspective about how we can think about the immune responses in sepsis and why understanding that way could help us think about vaccines differently. And we want to really think about the unknowns in the vaccine biology of sepsis survivorship. How do we quantify the impact of vaccines as a primary prevention strategy? How do we vaccinate sepsis survivors in terms of the timing and the vaccines we're going to use? How do we use novel vaccination approaches that target heterologous vaccine effects? And I've highlighted to you vaccine trial, which will be published soon. And it's an important start to tackle the problem. It is by no means the end of the research in the space, because there's lots of uncertainties that we don't tackle, but it's an important paper to get us started. I'll stop there, and thank you so much for the opportunity to present this work.
Thank you so much, Manu, for this very exciting talk. Um, this was really helpful in understanding the complex host response in sepsis and highlighting potential targets for restoring, if restoring is an appropriate word, a physiological response,
Yeah.
in particular with the aim of preventing the long-term consequences of
Yes.
sepsis. So there are a couple of questions in the chat, and I will summarize some of them. So yeah. Okay, so there's one question related to the beginning of your talk about the role of antimicrobial resistance in the burden of sepsis and how the two issues connect themselves. And if I may, I would also uh, want you highlighting if, by the way, finding a vaccines against sepsis might not be helpful in the fight against antimicrobial resistance.
Okay. So antimicrobial resistance, totally important. I think in terms of how we tackle that, I think it's judicious antibiotic use because we are not going to develop new vaccines. So there are new antibiotics quickly. So there are a few things that people have done which I think helps move the field forward. One is the original pro rata trial, right, where a biomarker shortens the duration of antibiotics from 14 days to 7 days. You can even shorten it even more. The second is the Surviving Sepsis campaign kind of started to re-emphasize this notion that if you're in septic shock, you need to probably get in with antibiotics quicker. If you got no shock, you have a bit of time to understand what the pathogen is and give a more targeted antibiotic therapy. So a bit of targeting of antibiotic therapy, shortening the duration, and using a biomarker to help time the antibiotic therapy. So in terms of the relationship between AMR and the vaccination, I am not an expert in combining the two. So I will, if I may, I will just give a view about this, Djillali, because I think if we are thinking about pathogens causing infection, the AMR gene is not the driver of the host response. And I think it may be that there are opportunities to probably target the pathogen without thinking of the AMR gene. What I think AMR gene will be really, really useful is as a part of antimicrobial diagnostics. Because people conflate two things: a diagnosing a presence of a bacteria using PCR to it being a sepsis test. It is not. So we can do an antimicrobial diagnostics, and there the presence of an AMR gene will totally help with that scenario. And I think final point in that diagnostic space that often we don't really talk about is live pathogens versus pathogens that are dead. And I think the vitapams, or the signals from live pathogens, produce a different immune response. And I think we have completely ignored that question in the sepsis field. And I think that's something that we need to really highlight and discuss amongst the people who are involved in the research in this space. And I think I'll stop there. I don't know. I don't think I can do more about AMR.
Sure.
Yeah.
And there's another interesting questions from Jesus Villar in Spain. So it's about the issue of resolution,
Yeah.
and the fact that it's of course, as you highlighted, different than anti-inflammation.
Correct.
And he just asked whether the capacity of resolution might be affected by comorbidities, by age, and other potential factors, which are very common in patients that are admitted for sepsis in the ICU or in the hospital.
Yes. No, I think 100% agree with ESS. How can you not agree? So when you have I said the resolution is different from anti-inflammation. So at the onset, one of the things that is important, which is in minutes to hours, is the inflammatory cell infiltration and edema. And I think the resolution starts when you have the cell and edema clearance. And alongside that resolution mechanisms is the macrophage reprogramming and switching off of the NF kappa B, and then the destabilization of the pro-inflammatory SRC3 mechanism. So 100% agree, it is not a quick on-off switch, and it is an active process, and we need to do additional kind of work to tackle that. What I think we haven't done in the field of sepsis is say, okay, early on in the disease process, there is no point in giving pro-resolution treatments. You can continue to give anti-inflammatory treatments early on. There comes a point in the biology where the pro-resolution mechanisms could be switched on, and that's when you need to kind of do that. And we don't know the timing of that mechanisms. But we do know the kind of the drugs that target these mechanisms. For example, a low-dose aspirin, some of the lipid mediators, and some of the microbial products of short-chain fatty acids and other things have pro-resolution signals, and this may be relevant in persistent critical illness that cause late deaths. So the timing is important, and I think Isis is right in that we should think about that particular aspect of biology.
Thanks. And there's another question. This one is coming from Antonio Artigas, again in Spain, who is wondering about, you talk a little bit about the compartmentalization of the inflammatory response. And so he wanted you further explain the difference in immune response according to different organs and how this might impact the development of a vaccine.
Oh, gosh. Okay. So the first point, let me make an example for people who don't think in this space because of the expertise. So if you take an organ like, let's take lung and let's take spleen. Both lung and spleen have got different immune cell populations. Lung has got a macrophage, spleen has got a follicular dendritic cell, as an example. When you take acute inflammatory response in the lung, the impact of the acute inflammatory response on the endothelium is different because the endothelial tight junction is different from let's say, a liver tight junction. So the mechanism by which the inflammatory response results in a sequelae is different. The next is the ability of an organ to recruit a new inflammatory cell. Lung is so beautifully positioned to recruit neutrophils into it, whereas a secondary lymphoid organ like spleen is not as efficient as the lung. So there is definitely compartmentalization of inflammation, and there'll be different inflammatory profiles. And we make this point in one of the editorials that we wrote before, which is, if you were to take a simple epidemiology of mine says, if you take a 2x2 table and say blood is in a pro-inflammatory state or blood is in an immunosuppressed state, and you take a other side of the 2x2 table, lung is in a pro-inflammatory state and the lung is in an immunosuppressed state. If you then say, you then have 4 scenarios where lung and blood are pro-inflammatory, lung and blood are anti-inflammatory. Easy, because you know what to do. When there is a discordance between the immune states between the two organs, you have a problem, because if you were to stimulate the lung and if the blood is in a pro-inflammatory state, you will worsen inflammation, and the opposite. So totally agree, compartmentalization is important, and we haven't tackled remotely the problem. Is there any role in trying to understand compartmentalization of our treatments? Like, for example, instead of giving systemic steroids to everybody, have a measure of lung inflammation and give lung plus systemic steroids or just lung steroids. And I think that is something the field will need to evolve into. But compartmentalization is important. We don't know how to deal with it currently.
So in line with this, do you think that one may consider inhaled vaccine rather than systemic vaccination? As an example, when the lung is a predominant organ of...
So I didn't go into it. So There is a mucosal immunity and Th17 responses to vaccination, and you can have vaccines that target those specific mechanisms. And I think there is inhaled vaccinations for flu in kids, nasal vaccines, that's what they do. And there is a difference between how a child's immune system reacts to some of these inhaled vaccines versus the adult. So we need to kind of be cognizant of that. But yes, it is potentially possible. And I think I see he is just making a point that not all microorganisms have the same effect. I think I said that at the lecture. So yeah, thanks for reinforcing that. Yeah.
Okay, so there's many other questions. We still have a few
Yeah.
times to answer some of them. So yeah, so I think Jesus again was suggesting about with the pandemic we have observed renewed interest in RNA vaccine, to build vaccine using messenger RNA. So how do you see this in sepsis vaccination?
I touched on this, and I think probably the the best use case that I could highlight is using a polyvalent vaccine, but at the moment we don't know which pathogen to target. So that is why I said in the talk, one opportunity here is to just say, look, in every sepsis patient, every post-surgical patient, every trauma patient, there is endotoxemia. People have shown that. And people have also shown that you can target the endotoxin. But what people haven't kind of thought about is just targeting the endotoxin enough as a preventative strategy? Because there is a recent endotoxin trial that isn't successful, at least from a press release. So there is a wider thinking to be done here, whether to combine the pathogen target with the pattern recognition receptor as a combination mechanism rather than as an individual mechanism. And I think because those are evolutionally conserved pathways, we will have consequences. And I think we need to be really careful how we address that particular aspect. If there was a high-risk population with a specific pathogen that is commonly associated with it, let me give you a crude example, is bronchiectasis and cystic fibrosis and pseudomonas. Then you can start to see how you can target some of those high-risk pathogens with a corresponding multivalent vaccine for targeted pathogens. But that doesn't prevent the challenge of overall sepsis, and that's why I think the heterologous vaccine effects could be important, but there is too much uncertainty. And we didn't really succeed with BCG during COVID, right? We tried. I think Mihai's wonderful work, they tried in healthy volunteers. The preventative mechanism as a primary prevention didn't quite work for COVID, but that doesn't mean that we can't really finesse the timing.
Yeah. Okay, and because all this you are highlighting, one question is, well, okay, if we have funding to invest, should we really go for vaccine, or should we go for other types of immune therapy, just like monoclonal antibodies or some recombinant proteins to modulate the immune response? So what is your guess about what in the next 5 to 10 years has a great chance of being successful in between the monoclonal antibodies versus vaccine or maybe other immune therapies?
Yeah. So we're talking about sepsis survivorship right now. Okay. So I think, Djillali, I think that's a very interesting point. So one, there are lots of uncertainties that needs addressing in that space alongside doing a clinical trial. And I think we really have to understand, do sepsis patients respond to the vaccines like normal people? Or when after sepsis would they do that? I think if there are immune impairments at the point at which we kind of identify a sepsis survivor, can we do some immunotherapies to restore that immune impairment so that they respond to things that we normally do like vaccines? So one way to tackle this is to have a platform of interventions, because the biological interactions can be addressed, and it also gives the best chance of finding something. You play the winner forward with almost like a seamless design, and that is probably the way to do it. It'll be efficient. It also gives us, in terms of timelines, a quicker from idea to output, so that patients can benefit. If we do it one at a time, I don't think it's going to be efficient, and we are all use public money to fund these sort of things, and I think it's important to be efficient about it and safe at the same time.
Okay, so another important question from Gilliana Tarp-Montalto. Because of the broad range of the deregulation of the immune response from hyperinflammation to hypoinflammation, and likely a dynamic process, meaning that patients may move from one state to another, should we not try to just first figure out ways to identify the best subphenotype as candidate for vaccination?
Okay, so I was hoping that I wouldn't have to tackle this. So there is a particular issue with the current approach to subtyping. We don't have a minimum set of standards to say what do we need to describe in a subtype. We don't use a consistent approach to analysis. We use different types of input data. Let me give you two examples that gives the challenge. So the original SRS subtype and MARS subtype based on transcriptome data. And the transcriptome data highlights 2 or 4 subtypes depending upon what it is. There is some overlap between them as shown in the recent Nature Medicine paper. And we've said that in our Lancet Respiratory Medicine review that if you do this, this is likely to happen, and that's what you see. At a biological level, effects are driven by proteins like cytokines and cells. The gene expression to protein relationship, even at a single cell level, is not correlated. In other words, not all the transcriptional mechanisms that you see will be the effector mechanisms of the bed space. So there is a translational gap that needs to be addressed. The other extreme of subtyping is alpha, beta, gamma, delta, as an example from Chris Seymour's work. That uses clinical data with minimal cytokine and other data. They don't really map onto any of the transcriptomic subtypes. So we don't know what is the right subtype. Then there is one other problem, which is time. All of this subtyping is based on heterogeneity of input data that is predicated on time at which you got the blood sample and their illness scores. So there are a few bits of knowledge that needs to be addressed before we get to the can we identify a subtype for a treatment. I think I would probably go at this stage, look for the variation in response to the vaccine, and then identify vaccine responder subtypes. People have done that in non-critical ill populations. There is a vaccine systems immunology consortium that highlights 3 levels of inflammation and vaccine response. And we can do that. I think there is a data out there, and we have done that in the vaccine paper, we have done that. So there are opportunities not to go by subtype, but by biology.
Thank you very much, Manu. We are approaching the end of that lecture, but before letting everyone going to the rest of their day, I would like you to end up with a very practical aspects for clinicians and patients. Is would you recommend in a patient who survives a septic episode that patient before going back home is vaccinated against pneumococcus, Haemophilus, and other existing vaccines, and in particular when a patient has frailty or risk factors?
Yeah, so great question, Djillali. So the honest answer is the timing, I don't know, but I would want them to be vaccinated. What I would recommend to clinicians and patients is to clinicians, if you know that the patient is recovering from sepsis and they're discharged from your care to the community or to a primary medical specialty or a surgical specialty, in the discharge summary code that this is sepsis and people need to follow them up because they're at higher risk of an adverse outcome. If you're a patient and you come back to a clinical setting for either worsening of your comorbidity, which often happens like cardiac failure or COPD, or something else like pain, tell them that you're recovering from sepsis, and that makes the clinician think about the reasons why you're having this episode differently. And I think that will be a big step forward from what we do currently.
Thank you so much, Manu, for this very excellent talk and the hour we spent together discussing of this very important topic. Thanks so much, and thanks to all who attended that your conference, again, from 21 different countries. And I would like to invite everyone for our next month's conference by Tom van der Poel from the Netherlands, who will talk about all the issues related to subphenotyping in patients with sepsis. Thanks so much. Have a great day. And
thanks, Djillali. Thank you very much.
See all of you next month. Bye-bye.
Bye.